chapter 4 in pathology. Where did we stop?
We stopped at
Bursitis.
101.
Bursitis.
That's chapter 4.
Yes.
We went over it.
We went over bursitis.
Yeah, and then you were like, that's it, we're done here.
Okay.
So we're on 102.
Okay. Let me find the next one that I actually covered on the registry. All right, so we're going to start on page 108. So with this chapter, you're really just going to have key terms, and I'm going to keep it specific to what they talk about on the registry. So we don't need to know more than they actually cover. When we talk about these skeletal pathologies, remember, we will probably have some kind of additive or destructive property. Whereas when we talk about chest or abdominal pathology, sometimes it won't actually change it. But these skeletals are very specific. So page 108, the first one we're going to talk about is osteoporosis. Osteoporosis. It's not listed in here, but the beginning stage of osteoporosis is also known as osteopenia. So osteopenia. You might want to write that down.
Beginning stage?
Yes. So it's kind of like pre-osteoporosis. So if you ever end up doing bone density studies or DEXAs, anybody seen a DEXA? Anybody seen a bone density study done? Yeah, so it's a really hard registry to pass, so I encourage you to do that. I would love to get the study material on that. It is very in-depth though. It's the study of bone, the density, and the development of it. So if you end up working as a tech who performs DEXA studies or bone density studies, or maybe you go to mammography, we do them a lot in breast centers, so they kind of pair them up together. Some smaller sites, like imaging centers, you'll end up doing all the DEXAs with x-ray. So they'll teach you how to use the equipment. It's a very basic scan. You take maybe 2 images and we compare them to a typical bone structure for the age to determine if your bones are weak or strong. So we determine the deficiency of the bone matrix. So is it hard or is it kind of brittle and softening? So osteopenia or osteoporosis might be noted on one of these reports. If it's pre-osteoporosis, they're going to relate it to osteopenia. If it's full on, determined by the algorithm of the machine, they will generalize it as osteoporosis. So do we think that this one is an additive or destructive? Destructive. So osteoporosis, it is eating away. So it's a generalized or localized deficiency of the bone matrix in which the mass of bone per unit is decreased in amount but normal in composition. So normal in composition, so the actual size of the bone isn't going to change, but the actual mass per bone of unit will be deficient. So we don't have as much density within the bones. The bones aren't shrinking, they aren't deteriorating, but it really puts people at risk of fractures because your bones are weakened within the core.
Porous? Like,
Yes.
Like spongy?
It is like spongy. Yes, exactly. What's the other name for spongy bone? Spongy bone, cancellous. Yep, spongy or cancellous. So she said, is it like spongy? Yes, it can appear this way. It can appear as though it's eating away. Sometimes you'll see osteoporosis present closer to joints. So the picture that they give you on page 108, it says diffuse, it's supposed to be diffused osteoporosis. See how around the joint spaces of the actual metacarpals that you actually see some black or gray areas? That's because the density is wearing out. So the actual core of the bone is fading, it is deficient. Everybody see it? The bone structure should appear more white, more contrasted in comparison to the soft tissue, but as we lose that density and that mineralization, we become more dark because we can penetrate through the bone quicker. So destructive for osteoporosis. Osteopenia is also considered destructive. It's not listed in this book, but I've seen it on a registry question before. So it's kind of like pre-osteoporosis. Pre-osteoporosis. All right, let's go to page 109, osteomalacia. So this refers to an insufficient mineralization of the adult skeleton, The lack of a balance between the osteoformation and the mineralization influencing bone quality results in either excessive osteoformation or more frequently insufficient mineralization. So our bones are fed by vitamins, right? Our blood is going into our bones. That's how our red blood cells are produced through the actual red bone marrow within the cavity of the bone. So osteomalacia, do you think it's an additive or a destructive? Destructive, good. So it's a destructive pathology. So we would need to decrease our technique if we knew that this patient was presenting with this. Again, if you image people and you don't know any of their history or you don't know their pathology, we can't modify the technique. If we did though, we would change it. It does happen a lot, right? That's why the people are getting x-rays, right? Because they want to be diagnosed. It's usually not a reoccurrence. Unless they have like osteogenesis imperfecta, things like that, you'll know. Maybe marble bone, osteopetrosis, they might know that already.
A lot of rheumatoid arthritis.
Rheumatoid
A lot of times
arthritis.
you can just tell.
Yes. And with our machines now, they're so sensitive to changes in density. A modification in technique is usually not required. However, we're keeping it on the registry, so we're gonna go through it like we would actually change our technique. Do you see techniques being changed clinically based on pathologies?
All the time.
You do?
Mostly on patient side.
Patient size, body habitus.
Yeah.
Not on pathology though, right?
No.
Right.
Well, we did a,
It depends after you take the first image.
After you take the first image, you might need to repeat it, right?
yeah,
But
if it's like
pre,
grainy.
but before you take the image, would you modify it? Do you know? Typically, no.
I mean, maybe if you know they just had a surgery or something.
If you knew they had a surgery, yes, especially if you're working with some kind of AEC and you're having them stand. If they have a metal plate or sometimes a pacemaker, you guys know how a chest x-ray can be distorted if they have that. So yes, I'd probably turn my AEC off and just manually do an exposure. Do you have a question, Ethan?
I did.
Think about it.
I'll just read.
Okay.
Osteomalacia and osteoporosis is very similar to me, other than the additive part of it.
Yes. It can potentially be additive, that's why they classify it differently, yes.
Wait, is it additive or destructive then?
It is, it's a destructive pathology overall. He's saying, can you add or decrease the mineralization of the osteoid formation?
If the
Okay.
osteomalacia was a lack of the mineral formation, that would technically be osteoporosis.
Right,
Only if it's additive is it.
right,
They're all done, yeah.
yes. All right, let's talk about gout. Anybody know anybody with gout on page 111? Know anybody with gout? X-rayed anybody with gout? Were you able to visualize the pathology? No? Yes? Maybe? All right, so gout, it's a disorder in which the metabolism of purine, which is a component of nucleic acids, in which an increase in the blood level of the uric acid levels leads to the deposit or deposition of uric acid crystals in the joints, cartilage, and the kidneys. This can be very, very painful. So basically, uric acid builds up, specifically within the joint areas, the hands and the feet. Gout is really present on feet, or feet images. Do you think it's additive or destructive if we are increasing the deposition of these crystals to actually cause
Destructive?
destructive? So uric acid will eat the actual joint. So think acid eating. So we're increasing crystals of uric acid, which will destruct the joint or the bone surrounding the joint. It is very painful though. Sometimes you can see little gout crystals if they're very calcified. If they're newly diagnosed or if they don't know if they have it, you might not be able to see it. Go to page 112. It shows you an actual picture of gout.
We don't have to know anything on rickets.
We don't need to know rickets. No, we don't need to know rickets. 112 gout. I like figure 450. You can see those actual crystals building up. But remember, the crystals are just composed of uric acid, which will eat the actual bone, joint space, and the bursa. So it can eat through the bursa. Very, very painful though. These are these really gross feet that you have to x-ray that you don't want to touch, that you double glove for, right? Kind of like a diabetic. All right, let's talk about Paget's disease. Paget's disease. You don't need to know the actual name of it, osteotis deformans. So Paget's disease, it's one of the most common chronic metabolic diseases of the skeleton. Destruction of the bone followed by a reparative process results in weakened, deformed, and thickened bone structures that tend to fracture easily. So this sounds confusing. So we're eating away, then we're building back up, then we're adding. So is it additive or destructive? It's additive overall. Because even though Paget's disease initially scoops out the matrix of the bone, it can appear as a cotton wool appearance, it will always build back up. So sometimes they relate it to initial stages of Paget's disease destructive, then it will be additive. The ASRT classifies it as an additive pathology because it will always increase the density. Always increase the density. It will tell you in this little paragraph about it, the destructive phase often predominates initially, but there will always be an additive component to it. So we classify it overall as an additive disease. I think they have a picture of it. Turn the page to page 114. So I don't know about the nuclear scan. I mean, I can obviously see that there's something going on with the skull, but I don't know how to read or depict these nuke med scans. But I do know as far as B and C goes on that image, B is the initial radiograph obtained during the destructive phase, whereas C is the reparative phase where it starts building back up. That is the cotton wool appearance. So if you ever see anything like that where it kind of has circles or wool type appearing on the skull, it's always Paget's disease. So it starts out as a destructive pathology, always moves into an additive. So overall classification of Paget's disease is additive. It will always be additive unless the person passes away first. Not a good life expectancy for this one. Very, very painful. I like the image on page 115 as well. It says Paget's disease of the knee. Note the characteristic cortical thickening, destruction of the fine trabeculae, and accentuation of the secondary trabeculae. So look at the striations on the bone. I mean, this is very abnormal, right? So at first it might eat the bone away, always going to increase it and build it back up. If it's not found within the skull and you don't see that cotton wool appearance of how the matrix of the skull is comprised, and it happens on like a long bone, like maybe you see it on a femur or a humerus, you'll always see striations, increasing striations if it's in the building phase or reparative stage. So when this person ends up going into late or chronic stage Paget's disease, their bones will be completely streaky and very thick appearing. Very thick appearing. That's kind of how we see it. 116, we don't need to know specifically ischemic necrosis of the bone, but overall necrosis. Do we think it's additive or destructive? Destructive. Good. So what's necrosis? What does it mean? Dying of tissue. Okay, so if your tissue is dying, we're not going to be building anything. We're not going to be adding anything to it. Okay, so we don't need to know that pathology specifically, but I definitely want you to know that necrosis of the bone or any kind of a structure in the body would lead to a decrease in factors. So we would always decrease our factors. How about edema? If we have fluid. Additive. Okay, good. How about tumor? Additive. Good. So just try to think about in terms of basic what the structure actually is. They might not specify the terminology for you. So they might plug in a weird word, like they might say an adenoma tumor. If it's a tumor, it's additive, okay? Even if they classify it as something. If it's necrosis of anything, necrosis of the liver, necrosis of the long bones, necrosis of the muscles, it's always going to be destructive. So don't let that trip you up if you see it on any registry questions. I've seen them throw in random pathologies that are not listed on there that we don't cover, but if they give you a main word like necrosis, tumor, any kind of fluid building, anything like that, the basic ones, we want to classify those as additive or destructive. So you don't need to know the specifics there. All right, page 119. This is my favorite pathology in this whole chapter. I like to call this one the broccoli tree. This is called the osteochondroma. Osteochondroma. Anybody seen one of these clinically? The picture is figure 463. Dang, I usually have one student. All right, so this is an exotosis, or a benign projection of a bone with a cartilaginous cap that arises in childhood or the teen years, especially surrounding the knees. So usually this is on the femur. So it's a structure that extends out. You have someone?
Yeah, it was a 9-year-old. She
Yeah.
came in last week and she had a bump on her leg and her mom was like freaking out about it.
Yeah. Yeah, so she had a bump like on her femur area?
Yeah, it was her femur that we were taking.
And was it large or small? Was it similar to this inside?
It was similar. Yeah. It was like a pretty large bump on her leg. It was probably about like this shape.
Yeah, so sometimes these dissipate if it's large enough or it impedes other anatomy. Sometimes they'll remove it. Painful to remove though, it's an extension of bone. So it's not just tissue.
Shave it off.
You can shave it off, it's very painful though. So typically they leave it, monitor it, observe it for the years. An osteochondroma is a good example of why we need to do an AP and a lateral, so 2 90-degree projections. If you image this in lateral, you might not actually see it being present at all. You might see a small density, but when you take that AP knee, you would always demonstrate it. It's gonna be more lateral or more medial, and you'll be able to see it. It usually presents as some type of bone, common pathology though, common one that you will see in your career at some point if you image pediatric patients, or I would say like somebody in early 20s that just didn't know that they had it. Sometimes these can dissipate and go away. It's like magic, right?
So is it bone or cartilage?
It's a bony cartilaginous cap. So it's bone protruding and then cartilage kind of caps it off to where it can't grow anymore.
Additive?
Additive, because we're increasing the bone. Additive, good. All right, multiple myeloma, page 126. Multiple myeloma. So while an osteochondroma is benign, multiple myeloma is malignant, meaning what? Cancerous, good. It can spread easily, so widespread. Multiple myeloma is basically bone and blood cancer, so blood and bone, so it includes both. It's really hard to treat because you have bone and blood all in your body, right? So the life expectancy of this is not good. The prognosis is not good once you have this. If you look at the image on page 126, figure 477, it appears as punched out osteolytic lesions scattered throughout the body. So it is slowly eating through the blood cells and the bone. Very painful. Destructive, yes. This one's gonna be classified as destructive. So it is named malignancy of plasma cells that may be associated with bone destruction, bone marrow failure, hypochondroplasia, renal failure, and recurrent infection. So because the blood is contaminated, the blood goes everywhere in our body. Because the bones are eaten up with cancer, fractures are very present. So figure 478, multiple myeloma patient of a femur. I mean, look at this bone. It's barely even there, right? This person is probably in late stage multiple myeloma. On page 127, it gives you another image, figure 479. This one is referring to the compression fracture on L2. Can you see the compression fracture on your image? So the actual vertebral body is very, very translucent or radiolucent. We can almost see right through it, so not a good thing, right? Bone mets, so bone metastasizing or bone metastases on page 127. We're not going to go over that one specifically, but what is a metastasizing cancer, or what is it?
Spread. It was bone cancer, now it's like liver cancer.
Good, so spreading cancer, spreading malignancy. So a MET is a secondary or a post-diagnosis of a cancer spreading throughout the body. So started out as lung cancer, now the person has breast mets. Started out as liver cancer, now the person has GI mets. So cancer or malignancy traveling through the body.
So don't know that, just kind of.
We just want to know what mets are in general. Yep. The fractures we are not going to go over. I gave you that worksheet earlier in the term, right? Yes. I gave you the worksheet earlier in the term that covers the ones that are actually on our registry. I would not read through all of these fractures in this book. Again, it's super detailed. I don't know all of the pathology in this. You don't need to know it. I do want to talk about on page 137, battered child syndrome. It is also known as SNAT. Anybody know what SNAT stands for? Suspected non-incidental trauma. Suspected non-incidental trauma. They classify this as shaken baby syndrome, Muchin syndrome by proxy, sudden infant death. All situations in which you have to prove that you did not do anything to hurt the child. So if somebody comes in and they say, my baby's been walking weird for a day, and then we x-ray the baby and they have bilateral femur fractures, we're probably gonna get a little concerned, right? So any type of pediatric facility has protocol for battered child syndrome or SNAT. If anything is suspected that it's non-incidental, they usually follow up with what? Do you guys know? Bone survey. Good, bone survey. This is where we would image basically the entire body of the child. So we're gonna do bilateral hands, bilateral forearms, humerized. We'll do a chest, usually just an AP, so that we can visualize the ribs as well. Abdomen, pelvis, femur, tib, fib, feet. Sometimes the skull, depending on the patient. These exams can be tricky. If you've ever assisted in one of these or seen one of these present, sometimes the parent is actually there, but they will never be able to just leave freely with the child. So, for instance, if we have a SNAT case in the ER, they'll come over to radiology, we'll set up, take all the images, the patient and the child will be monitored by somebody, usually a caseworker, and they will have to remain there until the radiologist does a stat read on the images. So they're gonna look at these immediately before they let the child go with them for the safety of the child, right? If it is a SNAT case, you'll see local authorities getting involved. You might see police officers or some kind of DCF worker there as well. Very sad cases. Sometimes when you have abusive people who have children, they can get very defensive. Like, why are you taking more x-rays? I don't want to take any more. I had a student last week that had an altercation with a parent. The parent said, no, I don't want you to take any more images of the patient. Well, in this case, you don't have the right to say that. So we have authority higher than the parent. So we have a DCF worker present, we have a caseworker present, we have a police officer present. So if you're ever involved in a case like that, just be careful. If you feel unsafe, grab another tech, leave your room, don't stay in, don't fight anybody. Of course, we want to protect the patient, but get help. So don't ever be in the room alone in these situations. Usually it takes at least 2 techs anyways though, because we want to get the exam done really quickly and we have a ton of images to take. Radiologists are trained and skilled at reading fractures as far as is it accidental or not. So they would know, is this a fracture that could be determined from a fall or is it blunt force trauma? Or is this person suffering from any type of pathology? They're gonna follow up. They're not just gonna assume that this patient doesn't have brittle bone disease or marble bones or something that would increase the risk of a fracture. So they're skilled at reading to determine if SNAT is present or not. And then it would follow up even further with more case studies. The end of this chapter, again, just more and more fractures. We are not going over all of these. We focus specifically on the ones that are in the registry. For the remainder of this class, I don't use this book, so you don't have to actually bring this book. You can bring your Bontrager book. The GI pathologies that are on the registry and the spine pathologies are in Bontrager. So it's just way too in-depth. If you would like to read more about it, you can follow up with this book. If you want to focus on the anatomy and physiology, I think they have really good pictures in this book. They have colored images, and they kind of switch them up from your typical Bontragers. So if you're kind of suffering or held back, you feel like in your anatomy and pathology, if you want to freshen up, you can. It has some good gallbladder pictures in the next chapter. But for the remainder of this course, you do not need to bring this book. We're going to be working on a Bontrager and just pulling out information. All right, everybody feel good about that?
Was the battered child syndrome additive or destructive?
Ooh,
Or just neither?
neither.
Okay.
SNAT is neither. So if you have a fracture present, we're not gonna change the pathology. If something starts necrosing or dying, we would change it then. Good question. All right, so I have a practice worksheet with you. I do want to talk about sinuses, so just a little bit more information before I let you go. Get out your Bontrager if you have it. Let's talk about sinuses. I want to talk about it and then demonstrate it, and then I'll let you go. All right, sinuses. Is it on around page 440-ish? All right, what's our routine? Let's start with lateral. Sinuses. I think it's around page 440.
436. Is Bontrager the same as with pathology?
Center of that.
Pathology or rad bio?
Yes.
Pathology, no, we're
Yep.
not.
437. 437 in the green book. If you have green. Yes.
We're tested on this, is it pathology or rad
Yes.
bio?
Pathology.
Okay.
Yes, we're gonna keep all of our extra information and Bontrager with pathology. We're gonna separate out rad bio. Rad bio is just safety and interaction. Physics, yeah. All the fun stuff. I know, my juniors are doing Ohm's Law right now. They hate me. Ohm's Law. Oh. Ohm's Law. Yeah, they do not like that. All right, so let's talk about lateral sinuses. So what is our orientation of our IR? Is it portrait or landscape? Lengthwise or crosswise? Portrait. Good, so it's gonna be straight. Our CR is what?
Midway.
Midway between the outer canthus, you can say it. Midway between the outer canthus and the EAM. Good, so outer canthus and EAM, if you need to see it visually. Outer canthus and EAM, right here. The only difference between this one and facial bones is facial bone CR also tells you zygoma. So zygoma. So obviously it's a facial bone, so they pull the facial bone to center. It's the same area, right? So portrait, what's our IR size? IR size. 8 by 10, good. 8 by 10. Anything else we need to know? SID?
40.
40. 40, good. 40. All right, so 40 just like our other skull projections. Anything we want to know? What about the line? Which line do we want to use? Should say something about the IPL. All right, so IOML perpendicular to the front edge of the IR. I know it's confusing. So IOML, so if I was measuring mine, it would be this one. So maybe about like this. I'm trying to think about if I'm perpendicular here to this. They also note something different on this one. They use the IPL being perpendicular to the IR. The IPL is this line right here. So the interpupillary line. So the IPL.
Which view are we doing right now?
Lateral.
Oh, okay.
Lateral. Yes, lateral. So this is our IPL. So it says if your IPL is perpendicular, imagine I am turned sideways here, so I'm lateral. Here's my image receptor over here. You guys are my X-ray tube. If my IPL is perpendicular, I have no tilt. If it's not, I'm tilted. So that's why they note that on there. So if you have tilt, the IPL would not be perpendicular to the image receptor. Anything else we need to know about lateral sinuses? I don't think so.
Must be erect.
Must be erect. All sinus projections must be erect. Yes, you want to write that if you don't know it. Why?
Air fluid levels.
Air fluid levels, right? That's the answer to everything, right? Air fluid levels of what?
Your sinuses.
Your sinuses, good. So if you have gunky stuff in your sinuses, sinusitis maybe, it's all gonna float down. It's all gonna float down, the air's gonna go up, hypothetically. Yes?
So, wait, are we gonna do Caldwell next, or are you just
Mhm.
asking in general?
Yes, we're gonna do Caldwell next.
Okay, never mind.
Yep.
Go on.
All right, let's go to Caldwell. Good time, good transition time. Caldwell, so what is different versus facial bones and sinus, Caldwell?
Horizontal beam.
Horizontal beam. Horizontal beam, no angle. So we don't use an actual angle. Remember in the other Caldwells for the facial bones and the skull, we put an angle on the tube, right? Up or down, caudal or cephalad? Down, good, so caudal. So for a sinus, we don't want to actually angle the tube because when we throw an axial angulation on the tube, it will distort the actual anatomy or physiology present. So what do we do instead? We
Go like
angle
this.
the face, right? Angle the face. So we do what to the OML? Does it tell you? 15 degrees down. So about 15 degrees down. So you should see your person rotating. You'll initially start out probably OML perpendicular, and then 15 degrees, is it down or up?
It says down. It says OML 15 degrees from horizontal.
It's up.
Extend or
It's
elevate.
up, yes.
It's connected to the elbow.
Yes, it's up. So the opposite of what you were doing before with the angle. If you put the tube angle down, you angle the patient up. So we put the tube angle down for facial bones and for skull, and then for sinus, we angle up. So we elevate the OML about 15 degrees. So we could start out initially like this, if the IR was in front of me, and then we would angle this up about 15 degrees, yes.
So I got kind of confused in clinicals like a few weeks ago because they were doing it, but they shot it AP
Oh,
instead of PA. So then if you shot it AP, then would you look down?
Yes.
It's opposite?
Yes. Yep. If you turn the body completely around, it would be opposite, so it would be down. Yes. I haven't seen it performed AP though, so maybe it's like a trauma situation. Patient had like damage to the face.
Or it was like post-op or something.
Okay. Yes, that makes sense. Post-op of nasal septum, so deviated
like
septum, something like that. Yeah, that makes sense. All right, so we're going to turn the body or rotate the face up, elevating the OML about 15 degrees, keeping the beam or the CR perpendicular to the IR so we don't distort the air fluid levels. Feeling good about that one? Where do we exit?
The
Glabella, good. We're exiting out glabella. Exiting out glabella, good. Is it nasion?
I think so.
Oh, sorry, it's
Sarah.
nasion.
You sure?
Yeah, you are.
Where does
Because it's still a Caldwell, so it should be nasion. So exit point remains the same as a Caldwell. Exit point is still nasion, right? So exit point stays, but instead of angling the beam, we're going to elevate the OML so that we can keep the true level of the parasinuses true.
So basically it'll be like this, the 15
Up.
degree down.
It'll be up,
For
15
PA?
degrees up.
Right. I thought you said up for 8.
Up for PA, down for AP. She said that she was doing AP
Down
and she went
AP.
down. Yeah. That's not a typical projection though.
That's weird.
You want to focus it on PA is what you're going to see it in the book at least. Elevating the OML from the horizontal line. So think about the horizon, the horizontal line, and you elevating the OML up. So you're looking up. It's kind of like a baby waters, if you will. All right, so let's talk about the waters, open mouth waters. Okay, so how do we perform it? We stay consistent with our image receptor, right? What's the size? 8 by 10. Portrait still. We want to visualize the sinuses, so we only need to really see right here, right? This small area of our face, so you can really collimate in if you want to. Where is our exit point? Acanthion, good. Parietal acanthion, so we should be exiting here. Masking days are here, so you might have to estimate or have them point to their top lip. You could do that if you wanted to. Patient and part position, still erect, still have them standing up, facing the image receptor. Which line are we going to use? MML, good, not mid-sagittal plane, but mental meatal line. So we're going to use this line here. So we want to elevate it to where it's perpendicular to the image receptor. So if I was standing in front of my image receptor, I would probably look something like this. Feel like I'm perpendicular, maybe. It's easier for me to position other people than myself. So we want to position this line right here, perpendicular to our image receptor. Once we have that, I like to take my hands, put it on the side of the person's face so they don't move it. Because if you tell somebody, open your mouth, they're going to move their face. But if you put your hands here and say, open your mouth, they just drop the jaw. So that's the instructions in the book, dropping the jaw without moving the face. When you actually drop the jaw, your mental meatal line is going to change, right? It's moving. So don't worry about that. That's why we position that first. So your mental meatal line will no longer be perpendicular to your image receptor once you have the jaw dropped. That's why you initially do that.
A waters and then an open mouth waters?
Yeah, sure.
Okay.
Sure. So open mouth waters, why do we open the mouth for this one?
So the teeth, sphenoid.
Teeth, right. So we want to move the teeth so that we can be able to visualize or see the sphenoid sinus. The sphenoid sinus. So it is demonstrated when you open your mouth, you're going to be able to see it within the cavity. If you keep the mouth closed, the teeth are going to obstruct the view, so you wouldn't be able to see the full sinuses. Very common, very routine. Anybody did these clinically? If you have done a sinus, yeah, some people have. You should see it, but remember, mental meatal line first. Hold the face or put your hands on the side of their face like this, and then have them drop the jaw. Your exit point, still a canthion. It shouldn't change. You're entering in the parietal region, exiting out a canthion. Do you want to see it demonstrated in the lab? You feel comfortable. It's basically facial bones. We're just not angling for that Caldwell. We're modifying the face, and we're opening the mouth for the waters. So not much change. It's pretty similar. What else do you want to go through for skull positioning before we get to that final rotation in our fifth room? What else do you guys need help with? I know somebody wanted to go over special projections for skull, so we'll do that. We'll do like trauma skull, trauma zero, reverse waters, reverse Caldwell, things like that.
Is that like PA or AP versus?
Yes. Yep, in trauma situations. So we'll do a cross table lateral skull if your patient was on a backboard. We can talk about those. Anything else? Do you guys feel good about mandible?
When it's on the candidate.
Okay. Do we want to go through that? Do you know how to center as far as the axiolaterals go for the body, the mentum, general survey?
I winged it.
Okay, let's go through it then. So next week, I want you to have mandible done, okay? Do a matrix on mandible. Let me give you your page numbers. Thank you. I think it's before this. So there's SRT. So we're gonna do PA. All right, so page 430. I want you to do the PA, not the PA axial, so the PA on page 430. Page 429, axiolateral oblique. Axiolateral oblique. So there's 3 methods. You could split the 25 degrees with a head tilt or an angle of the tube. So this is where it kind of gets complex. So a head tilt, yes. No, this one, oh, PA for the first one. So 430, not PA axial, because there's 2 on one page. And then page 429, axiolateral oblique. Axiolateral oblique. So you need to know all of them. So how do we turn the part to demonstrate the ramus, general survey, the body, and the mentum? So I want you to know all of them because they can test you on all of them. We generally only do general survey in clinicals. So you're not going to see the actual part being changed, but you know you can do it. And then your last one is going to be the town. So page 431, AP axial, projection of the mandible, the town. So 3 projections. So bring that in next time. We'll talk about it. We can demonstrate it too.
So you want
Next.
all 3 of the axiolateral oblique?
Yes. So mentum, ramus, general survey. Yeah. You need to know all of them. And body, there's 4. Ramus, general survey, body, and mentum. There's 4. We're doing our presentations next week, so I don't know how much time we're actually going to have to cover material. Hopefully, a little bit more time. We don't have that many classes left, right? You guys are almost there. Yes.
For the presentation, so I was looking at the rubric, but can you just kind of explain, like, does it have to be timed, or can we just do as long as we?
It's not going to be timed. I just want to know that you actually know the information.
Like, know what we're talking about.
Yes. So no reading off papers, remember? So you can use note cards if you want to, but just explain the modality and explain the pathology that you're demonstrating. Okay.
You have pictures, 2 pictures.
You can have pictures for the presentation if you want. Yeah. Do you want me to make a discussion board for you to upload them?
No.
Would that be easier? No? You're good.
So we don't need to have images. That would be.
You don't have to now.
If you want.
If you would like to, if it's easier to explain a picture, feel free to do that. I'll create a discussion board. If you want to actually post your pictures there so you can pull them up quick, we can do that too. All right,
So it
everybody.
doesn't have to be a PowerPoint.
It does not have to. Yeah.
I like PowerPoint. Yeah,
I like
me
PowerPoints too, right? I like PowerPoints too. All right, how are you guys? You good?
So we can do a PowerPoint?
Okay. All right. right, have a good day. See you next week.